going to do to get the scope minimally to the splenic flexure and safely. Excellent. So what else do we need on to make that work? Good. Yep. Suction doesn't really matter on the. You've done it. Absolutely. What should be off before we advance the scope into the patient? What should be off before, or disengaged before we pass the scope into the patient? And it's a trick question. By default, yes, but what else? It's a trick question.
What should be off?
What should not be engaged? What should be off?
There is something in the scope that should not be.
We did not touch on it, so it is a trick question. So what else is on that scope?
Do you have the same scope?
Oh, we do.
Do you have the same device? Do you have that device there? What is it? What is it?
Right, so
But I don't know how to use it.
no worries. Well, let's do this bit, then we'll talk about stiffness and but that should always be on 0. Okay? So that should be off.
That's why I asked. You haven't used the scope, don't worry. But if you've got a stiffening scope, then it should be on 0. Yeah, you've got the stiffening scope, but I don't know how to use it. No, how to use it. Hopefully, okay, we check the beats for proper alignment. Whether they're free or not, at the least position. So we turn on the light. I'm going to do as Paul does. First time, let's see what happens. Okay, we usually do the PR.
Yeah, not a problem. Excellent. Well done. Now, when you start to scope, and I know, where does your trainer, where does your professor normally stand when he supports you? If he's not in the room, be honest. Does your professor normally say, call me if you want me, at this point, and then disappear?
It's exactly back because in our setup we haven't got the screen, we've got only this.
Okay.
So you know our neck is usually strained after.
Okay, so you're struggling to see that, but
But
he's...
our supervisor is sitting there.
Okay,
His view, he can see the screen easily.
okay.
He sits there, and we've usually got a evil assistant with a nurse over this side. This is the first time I'm looking at that.
Excellent. Good. Excellent. And just slow down. Slow down, you'll make this in one move. That's brilliant. Well done indeed. Well done. Excellent. Now, keep the tip, not that, hold that still. Now, if you apply a little bit of clockwise torque with your right hand and draw the scope back 2 centimetres only. Now go forward and tip up. You don't have to bring that left hand across too far. Just let the left hand relax. That's good. Now tip up. Now, how did that feel that when you pull the scope back? So what happens is that the scope goes round. And then if you watch the elbow, the scope continues to do this. And it wants to go forward, and it continues. But if he draws the scope back, it then sat, and then it goes forward. So drawing it back just 2 centimetres. So what we'll say to you is stop. Now, excellent what you've done. Absolutely spot on. Now what we'll say to you is stop. Now we may sometimes say to you, draw back the scope, and then as we say that, you'll draw back the scope. So I don't do that, and Vakar don't do that. What we'll say is slowly. So how we want it is more important than what we want. What we want is slowly, by 2 centimetres, draw back the scope. And then that tells you what we want. As soon as you hear draw back the scope, you'll just pull back the scope. And that is not a good thing to do, because then we have to repeat what we've done to get where we were. So often the instruction or the guidance that we give is given, but it's given in the wrong order. So think about your professors, about how they've been supporting you. Think about the times when they've been getting a little bit frustrated. Think about the time that you felt pressured and you've tried to complete a procedure or a task in that procedure before the professor has finished what they're saying. And if you actually finished and listened to what the professor was saying, it may not necessarily be in the right order, but because you've allowed him to finish, you can then work out what you want him to do. So if I said to you, draw back the scope, slowly 2 centimetres, you'll have already started drawing back the scope. If I say to you, by 2 centimetres, slowly draw back the scope, that gives you a guided instruction. And so what you've got, it's how difficult sometimes it is to support people while they're doing it. So it's, when you come here, we're not knocking your professors. What we're doing is saying, look, if it's said to you in this way, it might actually help you when you're in a certain stage. It's a more encouraging way, but the encouraging way, it takes away the demand for you to think too hard about what you're doing. And when you get to a certain stage, we'll just say stop there for a moment, draw back, and you'll do automatically what we've asked you to do all the time, which is 2 centimetres and slowly. Yeah? Away you go.
Okay, now I am now at this position.
Okay.
This is not a very comfortable position.
All right. So relax. Let the left hand come down. Let the left hand come down. Right? More. Let the scope sit on the bed. Straight. Let the left hand point to the floor. Put the big wheel forward. Now do a slight clockwise torque. What's different?
It's a bit stiff.
It's a bit stiff. Draw the scope back. Slowly. Ah, you see. So I did that on purpose. Now, tip up. Now, how does that feel? Yeah? Look at your posture. That's not too much. Yep, tip up. Good. Increase your torque. Well done. Tip up. Good man. Advance your scope. Keep the torque on. No, you don't need to move your left hand. Keep going. Keep going. And stop. So how are you going to, where should you be approximately? Okay. So what position would you like one of your supporting colleagues to slowly, and this is the most important bit, when you ask a patient to move, you don't ask the patient to move. Now sometimes they'll jump around. So you want the patient again to slowly move. So change the patient. So what position would you like your colleague here to slowly move the patient into? Okay. Would you mind doing that?
Paul, I want to do it in the left later because that is usually the position. I haven't seen any of my consultants or supervisor done it in the right later.
Okay. Well, I've shown you earlier that on the mannequin it won't work. On the mannequin it won't work. And there you go. And now slowly bring it up. Brilliant. And now what are you going to do? Before you do anything, what are you going to do?
Visualize where I see where I am.
Draw back the scope a centimetre. That's it. Now go forward.
Okay, now I'm relaxed.
Yeah. Stand up straight. Be proud of who you are. Your mother loved you. Always think, when you stood there and everyone's looking. Now, how many times have you been in the room and you've been scoping? And now can you see all these people? They're all looking at you. Have you ever thought of that when you've been scoping? Everybody's looking at you. And all these cameras, they're looking at you. How does that make you feel?
Just a bit nervous.
No, only nervous? Should it make you proud?
That was celebrity.
So, where's the scope at the moment?
Uh,
Outside the patient. Well, how's the scope sitting outside the patient? So just drop your hand a little bit. Put the scope a little bit further south. No, don't take it out. South. So,
back.
no, this. There. Now, how does that feel? Don't crunch yourself up. Stand up tall. Your mother loves you. Draw back the scope.
Draw back.
Draw back 2 centimetres. Now go forward. Tipple. How does that feel? A lot better. And tipple. And further. And further. So if we put the patient onto the back now, and then you have a look inside. Would you like to do that? Have a look inside. So this is scope guide now. So what we do is we get a great big scalpel and we open our patients up to see what's inside. So we're roughly around here. Okay? So because it's the mannequin and it's quite sticky, we're not going to do much with it. We will lubricate it up. What we want to do is see how you handle a scope. The idea of this session isn't for you to get all the way around. The idea of this session is to see how you handle a scope, to give us an idea of where you are with your scope handling skills. Also to see where you are with your listening skills. So if you understand what I'm saying, you've got no problems understanding him. You know, if you understand him, you've got no chance of understanding me. So what you've got to do, if you notice what we do as well, we actually enjoy what we do. We like what we do. We like to see a smile on your face. We want you to be as good as what you can be. We want you to be relaxed. If you're relaxed, now just do me a favour. Grab that scope and grab it in a fist. See how the bowel's stiffened up here? Now relax the scope. See how it... Now if you've got tension in that bowel, by you causing it, you cause pain. Any stretching on the mesentery will cause pain. And that's the big thing. So if we go back to what we've done today, how does that, what we've done so far, feel? How do you think it's gone? Have you learnt anything from this morning?
Yeah, I've learned a lot.
What have you actually learned?
Well, I think we should consider the scope as a part of ourselves. I wasn't doing that before. And keep it relaxed as our body. Because I was a bit tight as well before in my program.
Yeah.
And just to relax and slow down a bit helps a lot.
Excellent.
Makes things easier. And that is
And enjoy yourself.
and enjoy it.
Anybody else? What do you think? Yeah?
Our main problem of ours is to rush
Rush.
initially. For the beginners,
Okay.
we try to finish it as soon as possible.
Okay.
For that,
Why?
because we stuck.
Okay. So how long does it normally take your trainer, your supporter, to actually get you around, your supervisor? How long would it normally take them?
They don't allow us more than 10 minutes.
Right. And how long does it take them to get round?
They take too much time, but they don't allow us to take
Okay.
more than 10 minutes.
Okay.
Yes.
Is that right? So, me myself, it's a bit like a learning contract. I'd rather you do 1 or 2 really well. So if you've got a list of 8 patients, try to get an agreement with your trainer or your supporter, your supervisor. Let me try 2. And then when you perfect and get that skill going, let me try 3. You don't have to do every patient. If you do every patient and you're rushing, you're just going to repeat the same error and same error. If they afford you the time to do and repeat the things that you get shown over the next few days on 2 patients, soon you'll be doing it on 3 patients, because your speed picks up, because your ability to actually make adjustments picks up. Once you've done 3 patients, shortly after that it'll be 4. Shortly after that it'll be 5. What you want to do, you want to try and impress, you want to try and do all of it. No, think about what's important to you at this time. Do you need to practice and get used to it, or do you need to continue to rush and then not make any advantage of coming here? And the best opportunity you've got is what you look at what you've got here, critique what we give you here, go back to your place and then optimize your learning. Better to do 1 or 2 really well than 6, 8 terrible, because you're just going to keep repeating it. Yeah? The other option is do 2 really well and 6 crap. That means awful. Right, if we just take it out, brilliant. So how did you feel about that?
Quite good.
Quite good, not really good.
Excellent.
Excellent. So we've got a happy man.
Yeah.
How does this work? Just, can we have the light off? So this is the stiffness. Yep. Anybody any idea what it's used for? Yeah, and I know you were on the last course, so you got the answer. It does make it more rigid. Where does it make it more rigid? This part, the whole lot, from here to here, from here to here, here to here. What part of the scope is made more rigid? The tip? This bit? Yeah? The whole scope? Nothing but the scope? That's a play on what they say in court in England. The whole truth, nothing but the truth. Okay? So we've got the scope, no stiffness, no stiffness, no stiffness, no stiffness. So this is without the stiffness. Can you see? See how it works? Yeah? Where does the scope commonly loop?
In the sigmoid.
In the sigmoid.
Sigmoid.
So, if that's the case, now you're thinking what it's used for. It's to supposedly to try and help reduce sigmoid looping. So if we actually apply, now can you see what I do? I keep the scope between 2 fingers. I apply these 2 fingers here. I don't put the scope against this because you'll damage the scope. Now you see these numbers, 1, 2, 3. Ignore the numbers. Anybody who tells you, applying the stiffness, going to number 1. Oh, that doesn't work. I'm going to number 2. I'm going to number 3. I'm going to tell you, for the cameras, garbage. It's either on or off. Off or on. All this bit where they say, we'll go stage 1, stage 2. It's garbage, utter garbage. So we've got the scope. Now look at the scope. Stiffness. Stiffness. Now look at this. Look at the scope. Look at the size it takes now. Look at the space it occupies. Yeah? And then as we get past this point, it goes back to normal. So the stiffness really affects from here to here, which is where the sigmoid is, to try and keep the sigmoid straight.
Usually the loops buried around this part.
Around this part. Now the problem with it, it makes the scope very, very stiff. So with the scope being very, very stiff, it then becomes very, very painful. So we only put on as much scope as what we need, as in much stiffness, what we need for a short period of time. Once you apply the stiffness, if you ever have to apply it, draw back the scope. Don't just advance. So, Eric, could you put the stiffness on, my friend, and watch what this does. Watch what it does. See the scope? Pushes. So while we've got it in that position, it pushed. So it is already causing stretching on the mesentery. We've already made it more. So we draw back the scope. That reduces it back to where it was. Then we can advance the scope. Yep. Then we take the stiffness off. As soon as we take the stiffness off, we draw back the scope, and then we can advance the scope. So stiffness, if we're actually going to use
When
it,
should we apply the stiffness?
when all else fails. So there is a mantra, there is a guidance what we do. And normally it's advance the scope till we get discomfort or pain. Right? We should try to avoid pain, but it's not natural to have this up your bottom. So you are going to have discomfort. But if you get a lot of discomfort, it could be air, or it could be that you got a lot of scope in. If you're causing pain, there's a lot of issues. But it could also be that the nurse or one of you guys, have you got pain? Oh, I have got pain. Have you got some discomfort? Yes, I've got some discomfort. If you tell them what it is, they'll tell you what it isn't. So you need to know. So if you plant the seed of pain, it will be pain. If you ask them, are they uncomfortable? They'll say, no, it's pain. That's different. But if you actually start off, is it uncomfortable? Then you can actually do something about it. That's, you're avoiding pain. Patient is lay on the bed, you're scoping. Apart from looking at the screen, the first thing to move on a patient who starts to get discomfort is the feet. So as soon as the feet move, stop, look, are you okay? So those are the things you've got to do. You've got to actually think about what you're doing. When we've actually got a scope, can you see this? This is very similar to a normal person's abdomen. We put the scope in. Look at how big this scope is. When we see it in this setup, we should only have about that much scope in. Can you see? Now when you see this amount of scope, we actually think, oh, well that's not a lot. But often we'll see this amount of scope in. So if we were to put this, have you got that, Eric? Hold it. Great stuff. Amount of scope in. How much scope? How many times have you seen that here? Many times. Does that make you now worried?
It's 1, 2, 3.
So we've got one surgeon, and when you go and watch surgery, and I would advise you to take a refresher, you gastro boys, go take a refresher. When they've got somebody open, just show me how thin the cecum is. And it is very thin. And then have a look at the rest of the bowel, especially the sigmoid. It's slightly thicker, but it's still thin. The more air you put in, the thinner it becomes. So can you see what we've got? Scope up to this, and how much scope we've got in. That should make you worried. So when we actually take this out, look at how much that space that takes up as we take out that scope. Look at how much it does. Look, and then we do this, and it flicks, and it does all this type of stuff. Watch it again. Oh, ah, oh. You know what I mean? Yeah? So when you get that explained to you, does that make you feel a little bit barbaric sometimes? So we slowly, steadily, you've seen now in this how much space. This isn't in you and I, it's not, the scope can go this way. The scope can come anterior, it can go posterior. There's some people like me where there's a lot more room. Somewhere like you, there's not a lot of room. You'd be easy to scope. I'd be very easy to scope. You're hard to scope. She's slight, everything small, but you also, the other thing about ladies is that they've got a large pelvis, so you lose a lot of scope into the pelvis, so you have to sort something out very early on. But when you see now this inside here, it should make you a bit more mindful about how you put the scope in. So when we put the scope in, how many of you have done this? And then done this? How many of you have had the scope? Pick the scope up, Eric. Pick it up. That's great. Let's get the scope in a certain position. I'll show you now. So hold the scope. So we've got this. I'm just going to pop it underneath here. Right? This isn't going to damage the scope in any way, shape or form. Right? So we've got this effect. I want you to hold it like this. Right? And then people get the scope and they push it down onto the bed. So rotate it. Look at it, force in there. See what it does? It pulls it. So rotate it. See it? And then you put it in. Everything. So it actually wants to lift this up.
Yeah.
And it pulls on the mesentery. Causes a lot of pain. You've got to be careful here because we get a lot of splenic injuries. And splenic tearing and shearing off the mucosa, because this area here, it's tied onto the back of the spleen, and you can tear this off the back. And you won't know anything about it except the blood pressure will drop. The pulse may not change. When they sit up, they've got a postural drop. So scope, nice and slow, nice and steady. See how much you've got here, see how little you've got here. Plenty of gel. Think it's your bottom. Any questions?
The question about the loop, if a loop forms,
Yeah.
the procedure you told us that turn it clockwise, then withdraw it, and then reinsert.
Okay. Right, let me show you. Hold the scope. Let's put a loop in the scope. Right? I'm going to show you how to do it. Hold it tight, so we'll just show you. Right? So as I take this scope out, I don't do that. See how much space it takes up. You guys will have been shown clockwise torque and withdraw. Yes? Would that be correct? You guys will have been shown clockwise torque and withdraw. See how much space that takes up. What we do is that we say slowly draw back, it gets tighter. Can you feel that tighter in the hand? Apply a little bit of clockwise torque. See how it got less?
Yeah.
If I put an anti, it gets tighter again. Continue to draw back, continue to draw back, continue to draw back, continue to draw, keep that, keeping it under control. And can you see how little space I took up?
Yeah.
But you guys have been taught this. Clockwise torque, see how much space? When I was doing it, because we did it slowly, yes, it's tight. Anti-clock, oh, it's tight. Oh, it's less tight. Continue to draw, oh, it's gone tight. Anti-clock, oh, it's tight. Oh, it's less tight. Keep going, oh, it's tight. Oh, it's tight. Anti-clockwise. Can you feel it want to push forward?
Yeah.
Now, that's the trick when you're actually going to do things with it, reducing a loop. If this tip cannot see down the lumen, there is no point in doing this, because that force you can feel pushing you forward, if this is against the bowel wall, it can push through. And that's when you get tip. And if you do this, that's when you'll get a perforation here. Tip perforation there, perforation here.
So we should reduce the looping only under visualization. You're saying that.
Keep the tip so it's pointing down the loop. If you are actually going to reduce a loop, and you say there's a loop, and I cannot go forward, I have lost one-to-one. Right? There's a big difference between patient is tolerating it and the scope is going forward. There's a big difference. Patient is tolerating it and I'm still going forward. Patient is tolerating it and I'm still going forward. Now is the time to reduce the loop.
This was what we discussed before, if you remember. You have loops that are friendly loops, loops. You can keep going as long as you're moving a patient, but there is a time where that will stop. When they stop, you reduce the scope and go further. Paul, we need to get the next one because you've got 10.
They're all done.
No, there's one,
Oh, one more.
hands on left.
Well done.
We've got about 15 minutes or so.
Okay, he's going to